Good evening and good day to everyone. It's good to be back. I am your host, Caroline, as always, and today we have another topic to discuss, and we have another special guest with another topic, as I've mentioned. And with us tonight, we have Dr. Tomas Frgala, who is the head physician at Unica Clinic located in Brno. So, hello, Dr. Tomas. How are you feeling tonight?
Hello, I'm fine. Yourself?
Yes, very good. I'm very happy that you are back with us. This is not your first
Thank you.
IVF webinar, so this is good to know that you have decided to come back here again and present another topic within our Stronger Together initiative. And
It's a
as
pleasure.
always, before we start with the presentation, I also want to mention that, of course, all those events, Stronger Together events, have been brought to you thanks to our ambassadors and partners. All of them are right here on the screen. So thank you so much for your constant support of this initiative. And as I mentioned, we will start with Dr. Thomas' presentation. Topic for today is why was your attempt unsuccessful and what to do next. And so, of course, Dr. Thomas will provide you with some tips on how to do it. So we will be able to explain some of the things on our topic, and then it will be time for your questions. So as always, all you need to do is just type the questions in the chat section so that Dr. Thomas can help you with those. So don't hesitate. You can do it now, later on during the presentation, or after the presentation, of course. And well, that is it from me. Okay, so Dr. Thomas, ready to start?
Yes, please.
Excellent. Thank you so much. Go ahead.
Thank you. All right. Hello. Good evening, ladies and gentlemen. Thank you for joining us tonight. Why was your attempt unsuccessful and what to do next is the title I chose for tonight's brief presentation as a part of the series labeled Successful IVF Treatment After Failed Attempts. In a number of early lectures, my dear colleagues discussed various quite specific topics focusing on the intricacies of planning the most fitting, the most promising IVF cycle. And these included quite detailed analyses of the individual aspects, such as various examination procedures or stimulation protocols. I thought we might want to take perhaps a slightly broader approach tonight, just for the change of pace, and at first try to define the term failed attempt. So what was actually the previous attempt? When and how should we proceed since it was unsuccessful? What do we wish for versus what might be recommended by the specialist? What is the most realistic and most effective way to go on? And ultimately, how does the eventual IVF cycle, the IVF stimulation, the in vitro fertilization following the stimulation of the patient's ovaries fit into the scheme of things? It's going to be quite different in a couple that has come after a spontaneous natural conception attempts. It's going to be markedly different in a couple that has actually been through some conservative treatment, including perhaps ovulation support, luteal phase support, intrauterine insemination. Once again, it's going to be very different in a couple that has been through an in vitro fertilization or IVF cycle with stimulation of the ovaries. And it's definitely going to be quite challenging in a couple that perhaps has been through a cycle with donated gametes already with no success. Of course, everything that I'm presenting here is not set in stone. It has to be discussed, considered, individualized, and that's the major point. That's the most important point. We have to know the patient, we have to know each other, and to be able to plan the future steps, the treatment accordingly. We need to focus at first on the patient's history, mainly their age, previous pregnancies, surgeries, other diagnoses, medications, test results, and previous treatment. The main factors we're trying to look at are the andrological factor, the the quality of the sperm. Here we can use the spermiogram analysis. We'll get to that in a bit more detail later. Then there's the ovarian factor, where we try to evaluate, let's say, the strength of the ovarian reserve in the woman based on AMH, or anti-Müllerian hormone, a blood test that is performed, or the AFC, antral follicle count, the number of follicles that we see in the ovaries with ultrasound. And these should go hand in hand. Basically, the higher, the better, to a certain level, of course. Then there's the third, the tubal factor, the patency of the fallopian tubes, and eventually the uterine factor and other factors. But these three are the major ones that we look at when we meet with the couple for the first time. Of course, I have mentioned age always plays a very important role in looking at that treatment algorithm and trying to decide to plan the next most successful step. It perhaps will sound a little one-sided now when I discuss this slide. I will focus on the age of the woman mainly, and it may sound like I forget the gentleman, I forget the part that the sperm cells play. It's not so. The spermiogram actually is quite often the decisive factor which points us towards a certain treatment. With a good spermiogram and passable fallopian tubes, we can talk about conservative treatment and eventually plan that. However, with the poor spermiogram, this wouldn't make much sense, and we have to talk about the IVF cycle much sooner. But let's focus on the age for now, because that also plays a very important role. In a couple, of course, where the woman, and this division into these categories is just very arbitrary, so don't put too much into it. But basically, when the woman is younger than 29, we can still consider conservative treatment if there's no other major problems. And we can go through the cycle monitoring, the folliculogenesis support, ovulation timing, luteal phase support, intrauterine insemination even, and only when these fail, okay, then we consider the IVF cycle. It's going to be quite different in a couple where the woman is 30 through 35. The conservative treatment option is still on the table, but we might think about the IVF cycle as the more sophisticated and more successful option sooner. Once again, it's going to be different in a couple where the woman is between 36 and 41, where the quality of the eggs starts to diminish. And in this group, the conservative treatment might be eventually considered a waste of time. So yes, it's still possible when all the results and everything points towards it, but we will definitely think about IVF much sooner, and will eventually have to think in some situations about the gamete donation already, about donated eggs or donated sperm cells. And last, in the couple where the woman is over 42, IVF can be tried, but the IVF cycle with egg donation actually, specifically here, it gives a much higher chance. This is a group of patients between, let's say, 40, 45, where the IVF cycle success rates are usually cited in literature somewhere between 1 and 3%, or 1 and 5%. With egg donation, we're constantly moving into a group with success rates around 55 through 60% following a transfer of one embryo. So it's important to realize that when we plan the treatment or the treatment sequence, depending on the age, we might step in at a certain point and take it from there eventually. But for now, let's focus actually on patients that have been through an IVF cycle already and are trying to plan the next step, to discuss the next step, because this seems the major point of the topic when we discuss successful IVF after a failed attempt. This failed attempt is mainly or mostly considered as a previous IVF cycle. And this, of course, is a much trickier group. Okay, so when we try to analyze the previous cycle, and this is always a part of the procedure, then we try to gather as much data as we have and try to build on that experience. So we look at the response of the ovaries to the previous stimulation, the number and morphology, the build of the cells that we were able to get, both on the side of the woman following the stimulation of the ovaries and the side of the gentleman. Because the spermiogram is always analyzed once again on the day of the egg fertilization. We look at the fertilization rate, how many eggs were successfully fertilized, at the development of the embryo in vitro, meaning in the lab, for those 5 days prior to the transfer, and eventually if there's a genetic testing, pre-implantation genetic testing for any ploidies performed, then we look at these results if available. And we try to specify, what went wrong and what step and what can we do about it eventually. If the quality of the gametes themselves, the reproductive cells, is low, or there's a poor fertilization rate or very poor embryogenesis, this is really tricky, and it's very hard to try to dig for specific and clear answers. And this is a group of patients where we might want to or might have to be forced to think about gamete donation earlier. It's similar in the second group where the development actually of the embryo might be promising. So a good number of eggs retrieved, a good fertilization rate, and perhaps even a good development of the embryos until day 5 with numerous blastocysts to choose from. But if the biopsies performed on day 5 for the pre-implantation genetic testing, and all or most of the embryos turn out to be aneuploid of poor chromosomal quality, once again, this is a difficult situation to try and address, because there's not many ways, if any, how to positively influence the quality of gametes. Once again, the age is a very important factor here. Another group is a patient with a negative pregnancy test following a transfer of a well-developed and euploid embryo, a healthy embryo, following the PGTA. And here, that's where it gets really frustrating, because everything seems to be working up to that point, and we're transferring a very nice embryo, and it's really frustrating to get a negative pregnancy test. Another group might be a patient who goes through multiple transfers with a negative result. After several transfers, we can start talking about the repeated implantation failure, and that's where we really try to push hard for answers and for additional examinations. And we cannot forget about another group in patients where actually the implantation of the embryo is successful and unfortunately is miscarried early, let's say during the first trimester, and that also gets very, very frustrating. Let's go to the next one then. So, what are the major influences on the outcome of the IVF cycle? Once again, age of both partners, very important. Quality of the gametes, of the reproductive cells. Then perhaps genetic factors, eventually, and these are already the factors that we don't necessarily look at the very beginning, unless there's a suspicion that something might be wrong, or a history in the family or in the patient herself or himself. But definitely between unsuccessful cycles or with these problems that we have just cited, repeated implantation failure, or an early miscarriage, we might look at the other factors such as hematology, so possible hereditary thrombophilia, a state where the blood in certain situations is coagulated too quickly, immunological factors, a very complex field, very difficult to interpret the results, but very interesting nevertheless. Eventually, the uterine abnormalities, and, well, the relatively simple one, the lifestyle influences. Smoking, bad. Body mass index, a high body mass index can also influence negatively the menstrual cycle, the stimulation, the response of the ovaries, and possibly even the quality of the gametes of the eggs. And stress, I know this is a tough one. Anytime a physician starts to talk about reducing stress, it stresses you to no limits, but we have to mention it as well. The one and main influence is the quality of the embryo itself. So we have to try and look at the quality of the gametes prior to the cycle, even prior to the first cycle. Of course, that's what takes us to the eventual first IVF, but also by trying to plan the next, the better IVF cycle with a stronger chance for success. The sperm cell quality, I'm not going to surprise anyone here. You have been probably, most of you, through these. So let's just take a look at it quickly. Here we do have some options. The very first one is a detailed spermiogram analysis. It's a basic analysis, kind of a rough estimate of the quality of the sperm cells, but it gives us an idea nevertheless, and it's a very good starting point. We can eventually have the DNA fragmentation in the sperm cells, have it analyzed in genetic lab, and maybe based on this or based on these results, then pick the optimal sperm selection method for perhaps ICSI, the intracytoplasmic sperm injection, where the selected sperm cell is inserted directly into an egg. And since usually during the stimulation, we get somewhere between, let's say, 2 and 20 eggs, depending on the response of the ovaries, we will need 2 through 20 sperm cells. While in the ejaculate, in the sample, there's usually millions of them or even hundreds of millions of them. So plenty to choose from, and the question is, how do we choose them? Here are some of the latest selection methods: PIXI or pre-selected ICSI. Perhaps more interesting or more current, MAX, the magnetic activated cell sorting method, where sperm cells with fragmented DNA are removed from the sample, or the latest one, the microfluidic sperm sorting chip. And based on the spermiogram and actually the results of the previous cycles, we can discuss these with the couple and recommend the appropriate ones. So that's as far as the sperm cells goes. With egg quality, it's much more difficult. There's basically no method that would let us evaluate the oocyte quality directly. So we'll have to talk generally about the function of the ovaries. And here's just a very rough division to patients with ovarian function, without it. We can look, as I have mentioned earlier, at the ovarian reserve, at the age, at the factors basically that can influence that ovarian reserve in a negative way: the age, the endometriosis, eventual surgery in the history of the patient. But as far as the quality of the egg goes, it's really difficult. We never really see the egg. There's just one usually hiding in the follicle, in the ovary during the normal, the menstrual or ovulation cycle. And even in the IVF cycle, when we actually stimulate the ovaries and win the eggs, obtain the eggs via the oocyte pickup, that's where following the so-called denudation, the embryologists do see the eggs for the first time, so they can comment on their build, their morphology, eventual fragmentations, and some obvious problems. This is all just a very rough commentary of the state of the eggs. How many are there, how many are ripe, and how many look sound as far as the structure goes. It doesn't give us a lot of data about the actual quality of the egg. So it's much tougher there. Regarding the quality of the resulting embryo itself, it's similar. The evaluation methods and the selection methods still quite heavily rely on the morphology, the build, the looks of the embryo, but there are actually some very interesting methods being regularly used now, such as the long cultivation until day 5, and eventually the time-lapse imaging technology, which lets us keep a closer eye on the embryo, its development, and it's much more comfortable for the embryo, and the pre-implantation genetic testing. Although it needs to be said that even the application of all of these methods and the selection of the most promising embryo with the pre-implantation genetic testing, it still does not guarantee the implantation of the embryo or a perfect development of the fetus. We have mentioned the uterine factor. I'm pretty much going to jump over that one because nowadays, at the age of the ultrasound, where actually every gynecologist has one, this is very rarely a surprise. This is usually a point where the patients come to the specialized clinic very well diagnosed and pre-treated already, because that's something that their gynecologists usually see during the regular checkups. So how do we try and increase the chances for the next IVF cycle? How we analyze carefully the available results, the treatment protocols. We think about the micromanipulation methods. These add-ons cost some extra money, so we need to take that into consideration as well. And we always think about the additional exams that might eventually help, be it the genetic consult after an unsuccessful cycle, repeated implantation failure, missed abortions. It's definitely a point where we shouldn't forget about the karyotype in both partners, eventually cystic fibrosis, mutations and microdeletion Y of the Y chromosome in the gentleman if the spermiogram is really poor. Hematology in the woman, the so-called hereditary thrombophilia, eventual and immunological consult. I'm not saying that you have to have all of these. This is just a list of ideas to eventually choose from and to consider. If everything else seems to be in check and there is no explanation for the lack of success, eventually there might be a hysteroscopy in order to check the uterine cavity and possibly take a biopsy, where the sample is then examined for the natural killer cells, the NK cells, and the plasma cell levels, which might actually show or point us towards a possible chronic inflammation of the uterine lining, the so-called chronic endometritis, where actually an antibiotic treatment might be helpful. So the hysteroscopy is also one of the more important methods to consider, especially after repeated implantation failure. And there are the more modern tests, such as the endometrial receptivity assay, the ERA test, to see what the optimal length of the progesterone application prior to transfer might be in the individual patient, and the EMA-ELIS test, the evaluation of the endometrial microbiome or microbial environment. But these are rather fresh, and we're still waiting for large studies that would definitely prove the efficacy of these methods. But it's something to consider and to discuss eventually. Okay, when none of these give us an answer, when we have been through repeated IVF cycles, and of course, in situations where, as I had mentioned earlier, there's problems with the gametes or with the embryos, or where the age is of a major issue, we might have to think eventually about the ultimate refuge. So when everything else fails, we might have to think about egg donation. Once again, this is in situations where the patient does not produce any more eggs of good quality, or of course, when she does not have ovaries at all, be it a genetic problem or a previous surgery, or when she suffers from unexplained premature ovarian insufficiency, poor oocyte quality, we have mentioned that, eventually endometriosis that can go hand in hand with the previous ones, or simply has surpassed the age where we can still rely on the egg quality. There are some clinics that after 45 don't stimulate the own ovaries of the patient. Some actually put that line, that limit at 45, but it is estimated in some studies that at 45, it's actually 90 through 100% of the eggs that are aneuploid of poor quality, and it's really, really rare to get a pregnancy from an own stimulation or a stimulation of the own ovaries of the patient. It's different in a couple where the stimulation has never been tried, and we always take into consideration the wish of the woman, the wish of the couple, and if it makes sense, okay, unless there's like a critical problem, then we can always try the stimulation. But the question is, how many do we try? I have seen some interesting studies that actually show that after 3 attempts, the curve that still gives us the chance and represents the increase of chances with every following attempt flattens out significantly. So it was mentioned that perhaps after 3, maybe 4 IVF cycles without success, it's time to consider the next step. But this doesn't necessarily need to be the rule. On the other hand, we have many patients, or you have heard about patients that have successfully gotten pregnant with own eggs after 6, 7, 8 IVF cycles. But usually after that, after 3, 4 stimulations, it's time to give it some serious thought. Time flies, and I've been talking for almost half an hour, so I don't want to spend too much time on this. I see that there's many questions popping up, and I want to give you enough time for the questions. So basically, when we do reach this ultimate refuge, when everything else fails, and we need to talk about donated eggs, let's just take a very quick look at this in a couple of minutes. Who are the donors? Young women who decide to volunteer and help somebody else. The rules and regulations are similar in most countries all over Europe, around the world. In the Czech Republic, the limit given by law as far as the age of the donor goes is between 18 and 35, but we usually take women between 20, 26, 20, 29, where the quality of the eggs is at best. In the Czech Republic, it's an anonymous procedure, so the identity of the donor cannot be revealed. On the other hand, the donor doesn't learn who received her eggs. The reasons for donation, this is actually not a study in the Czech Republic, but all over Europe. About half of the donors say it's just purely to help somebody else out. The other group actually comprises of donors who say that they want to help somebody, and the financial support that they get, not for the eggs, that makes it interesting for them. They have to be very thoroughly tested. This testing is actually not only compliant with the national and EU regulations in the Czech Republic, but in certain regards is more strict, because we have a very agile Society for Medical Genetics and Genomics, and since last year that there have been some extra tests included in the genetic screening, where many blood tests are performed, and they are actually listed here: karyotype, cystic fibrosis, muscular atrophy, connexin 26, and only following a genetic consult with the geneticist who says that everything's okay in the donor's family. She is a carrier of no mutations and no serious diagnoses, or actually no diagnoses at all, and that yes, she can donate only then she's included in the donation program. The matching, you have probably heard this, and if not, and we'll go through these in an eventual consult, is done based on the phenotype mainly and other factors. It's relatively simple physically, okay, not psychologically, of course, for the patient, because using estrogen pills, we need to prepare the endometrium, and at an exact point, at the right point, step in with the progesterone. But basically, it's just these pills and an ultrasound check to see if the endometrium is growing at a certain rate and has the right structure, so it's going to be ready for the implantation of the embryo. In the meantime, the donor is going through the injection applications, through the ultrasound checks the blood work, and eventually the oocyte pickup in complete anesthesia, after which the fertilization of the eggs is performed. The process of the endometrial growth we have mentioned briefly, and we'll stay at that at this time. The endometrium should be somewhere between 7 and 12 millimeters. Of course, 8 through 10 would be perfect, but this will be evaluated individually, and the dose of the estrogens can be adjusted accordingly, fitting the individual needs of the patient and her uterus. It's always good to get not one, but many or multiple eggs from the donor, because not every follicle during the stimulation will carry an egg. Not every egg will be ripe. Not every ripe egg will be healthy. Not every healthy egg that is fertilized will actually result in an embryo on the next day. And not every embryo that we start with is going to develop into a blastocyst on day 5. So to have a promising number of embryos following that 5-day cultivation, we want to start with a certain amount of eggs at the very beginning, and we have to be ready that we're going to lose some of these cells or some of these embryos throughout the treatment. But it's a natural selection process that gives us a chance actually to transfer only those embryos that are really fit for the implantation and that are promising for a further development. Okay, aside from staying in contact with your coordinator, your physician, your specialist, and the clinic, what else can you do after the transfer? Well, this is the phase where actually there's not much that we can still do. If the embryo is in a very good stage, if it has been developed or developing nicely, if the transfer was easy and the endometrium well built. Of course, we can talk about things like supporting your microbiome. We have touched that earlier, just very briefly. But basically, all we can do is keep taking the hormonal medications so that the endometrium stays stable, well-balanced diet. These are all tips or instructions for the patient herself. Exercising moderately. Of course, this limit can be different for everybody, but we all have our rules, and we all have our limits. Avoiding stress if at all possible, and avoiding harmful substances, obviously. But we also, at this phase, we need for the embryo to be strong, to do its work, to have this will to live, and we need a little bit of luck, or sometimes a whole lot of luck as well, but it all goes together, and hopefully, if not at the first attempt, then the second, third, fourth one, they might and should be successful. So I wish you all the best, and I thank you very much for your attention. And perhaps now it might be time for your questions. I'm going to do my best to try and answer most of them, and unless we have touched it already in the presentation, then we can go into detail as well. If that's not enough, then please stay in touch and eventually call one of our coordinators for a consult with the physician, and then we can even during these difficult times, we can start with the Skype consult, which makes it easy to start long distance. You can scan and email the documents. We'll go through those and we'll take it from there. Thank you once again, and I'm looking forward to your questions.
Wonderful. Thank you so much for such a lovely and interesting presentation, for so many details. It was indeed very, very interesting and useful for all of our patients, I am sure here. So yes, as you see, plenty of questions are right here as well. So let's not waste time and let's go to the questions. So thank you for those questions. We definitely have a lot of them. The first one is right here. Do intramural fibroids have a role in failed attempts, donor eggs?
Wow, okay, the very good question, a very tough one to start with, because there's no easy answer for that. This has been discussed for years and years and years, and the rules have been shifting. We need to realize that there's many forms or types of fibromas. The ones that grow outside of the uterus, the subserous myomas or fibromas, fibroids. They're not that problematic. Then there's the ones that grow inside the uterine cavity, the submucous fibroids. These are a big problem and should be removed possibly via hysteroscopy. But here we're actually discussing the ones that grow in the wall of the uterine cavity. And the rules have been changing actually over the years. The rules of 4 has been there for quite some time. If there's more than 4 myomas, fibroids, operate first and then perform the transfer. Or then another one was when the fibroma is larger than 4 centimeters in diameter, then operate. But currently, actually, the specialists, the experts in the field usually say when it's in the wall of the uterus, yes, if it's really large, it might play a certain role, but it shouldn't be a substantial role. And do not operate, try and perform the IVF cycle. And first, as long as the patient doesn't have any substantial problems, any pains, any cycle irregularities, irregular bleedings. So yes, they might play a certain role, but we don't operate until the patient has actually specific problems.
Perfect. Thank you so much for the very first question. Definitely a tough one, but thank you, Dr. Thomas, for answering this one. And let's go to the next one. My husband and I completed karyotype tests. Both were normal. However, I've had 2 failed frozen embryo transfers of high quality embryos. Do you suggest testing my embryos next time?
Very good question. Very good question. Okay. I take it the high quality of these embryos was probably just based on their morphology, on their development, and hopefully through day 5 of the development, because the day 3 is kind of inconclusive. But if these were high quality embryos on day 5, yes, this is something you might want to consider, especially if you have doubts about the next possible IVF attempt. Should you keep trying with your own eggs, or is there maybe an underlying problem that's not showing even though the karyotypes are okay? Once again, I do have to mention the age, and I'll get back to that in just a moment. And also I have to mention that while the PGT-A procedure, the testing, the genetic testing of the embryos is very helpful, it mainly serves as a method of embryo selection for the transfer. So it's especially helpful when you have multiple embryos. There are cycles sometimes where the patient or the couple, they have 7 embryos or 5 or 8. And when the patient goes through 7 transfers, those frozen embryo transfers, unsuccessfully, that gets very frustrating. So in a situation like this, good ovarian response, many embryos, it's definitely a good idea to do that. When there's just 1 or 2 embryos, it gets a little questionable, and it's especially tough to decide when the patient is around 40 or over 40, because they usually don't have so many embryos. And yes, the PGT-A with a poor result might actually prevent you from repeating the IVF cycle with your own eggs again, because it shows that there's a very little chance. I have had patients that came from another country. They are a patient with 40, very good AMH, successful stimulations, 9, 10, 11 oocytes. And after a 5-day cultivation, they had 4 or 5 or even 6 blastocysts in one of the attempts. I was asking, well, how many transfers? None. Why? All the embryos were aneuploid. So that's a situation where it might actually give you a clear suggestion. So generally, I would say yes, that's perhaps a good idea, but you have to take into account everything else, plus the price of the test, of course, as well. Thank you for the question.
Thank you indeed. And thank you also for your answer to that. Okay, let's have a look at the next question. I am in the process of going through a mock cycle for donor egg treatment. Can you give me any tips for success? I am 45, and have poor egg reserve.
Okay, thank you very much for the question, for the specification. That was actually very helpful. I understand, and I think that you're on the right track, because the donor egg treatment is definitely the way to go here. Fortunately, the ability of the uterus to take care of the pregnancy remains very strong until high age. So the fact that you're 45 does not play a role here, not anymore. The quality, the age, and the quality of the egg is important or decisive. And of course, the quality of the sperm cells eventually, and the right micromanipulation methods, and everything else. Now, pointers or tips for success for you personally. Well, if it's a mock cycle, the preparation cycle, definitely an ultrasound to check on the height of the endometrium. And then based on that, the dose of the estrogen hormones can be adjusted for the actual transfer cycle. So that might be very helpful. Otherwise, stay positive, eat your vitamins, and hope for the best. Otherwise, there's nothing that you can really do at this point to try and increase your chances. Of course, there's the things like I mentioned vitamins, okay, the folic acid or folates, but every clinic does that, and I'm quite sure you're taking these already. Otherwise, there's no real tricks that should be mentioned here, unless, of course, there's a problem on the ultrasound check. If there's a sign of a polyp or a cyst in the ovaries, then you might want to reconsider and maybe postpone the treatment, but I hope this is going to be the case. Good luck.
And excellent, thank you so much for that. And I just want you to see that, of course, there is a thank you for from the previous patient for your response right here, great response.
Okay, thanks, Chintan.
And let's have a look at the next question. So what if I have blood coagulation issues and also a rather big liver hemangioma? Sorry. Can I still try? And what about using heparin, aspirin? What would you suggest?
Oh, this is a very tough one. And I'm sorry, but it's actually sort of exceeding my expertise. If you do have blood coagulation issues, then you might be at risk while taking estrogen hormones or during the stimulation. So you're definitely candidate for the low molecular weight heparin injections. But as far as the question of the hemangioma goes, then you will have to talk about that with your specialist, okay? And they have to see and possibly monitor the treatment and say if a low molecular weight heparin application is like strictly forbidden, contraindicated, or if it's possible, but you'll have to be monitored closely, or if it's no problem at all, if they can also suggest the right dose. So this may be, of course, a tough issue, and it's one where you'll have to actually cooperate with both sides, with both your reproductive medicine specialist or assisted reproduction specialist, but also your practitioner or your internist or your hematologist, whoever actually does the follow-up on the hemangioma. That's a very tough one, and it needs to be solved carefully so that you can stay safe. That's always the number one point in any treatment.
And once again, thank you so much
Mhm.
for that. And next one is right here. I am a very healthy 38-year-old, and so is my husband. I have had 2 rounds of ICSI, resulting in many blastocyst transfers. I had my last round PGS tested, giving me 2 healthy blastocysts, but both transfers failed. My doctor
Mhm.
says everything in my uterus looks good, and my egg reserve looks very good. What should my next step be?
Okay, this is a tough one, of course. This is a tough one when everything is seemingly perfect and still no success. Um, if there was the PGS, the pre-implantation genetic screening, which is an older label for PGTA, performed, that usually means that both partners had a karyotype examination, and it was probably or very likely okay. It was normal, because otherwise you would have mentioned that. So genetics kind of is out of the question here. I would wonder about hematology, possible hematological issues. So many blastocyst transfers, that sounds like repeated implantation failure. So at least a blood test for the hereditary thrombophilia, factor 2 and factor 5, at least those two, and possibly eventually when you get a positive, a pathological result, then discussing this with the hematologist, maybe low molecular weight heparin could be applied. Another option is to discuss this with an immunologist, but it's tough to find a specialist for reproductive immunology and to have the perfect tests suggested. I couldn't even do that, and I turned the few immunologists that I know and respect, and I'm in awe of, because it's a very complex field. Last but not least, hysteroscopy, perhaps, unless it was performed, of course, but it says that the uterus looks good. This is probably based on the ultrasound, and this just as well. But after more than 3-4 unsuccessful transfers, I would perform or have the diagnostic hysteroscopy performed and check for signs for chronic endometritis or a chronic inflammation of the uterine cavity. Yeah, this is a tough one. Thank you. Thanks for the question. Very good one.
Yep, perfect. Of course, thank you so much for that. And actually, Kirsty has added that something here. So I had a laparoscopy. Everything looks good.
Okay, so laparoscopy is fine, but that's when you look in the uterine cavity and the pelvis. Usually hysteroscopy is a part of that. So I take it you probably had a hysteroscopy. Oh my, oh my, oh my. Yes, please. I don't mean to be rude, but 38, that is a slightly higher age from the reproductive point of view, okay, or the point of view of reproductive health. Once again, nature is quite tough here in that regard. I might not have mentioned that. I did mention it many of times in my previous talks, that it's different in the gentleman, who generally the man produces fresh sperm cells throughout his life. The woman gets born with all the eggs, and the eggs grow older with her, and that's why the quality of the eggs is best between 20 and 29. It's good until 35, and it's acceptable until 40. But in this group, 35 through 40, some literature actually states success rates around 14%. We have been more lucky or more successful, and we are usually looking at better numbers than that. But this shows you that the quality of the cells can be poorer. If you have very good response of the ovaries and many eggs, yes, and good development of the embryos, I would try again, yes. possibly with the PGTA, with the genetic testing of the embryos, and I would look into the hematological and possible immunological factors.
And wonderful. Once again, thanks for that as well. Okay, next question. It's two parts of it. Okay, so let me start with this one. I've just turned 42 and have had one IVF round with day 5 embryo transfer of good quality with failed implantation. Due to my age, I don't feel I have time to waste with possible multiple failed transfers. And the next part and question is right here. What is the minimum number of failed rounds of IVF would you suggest before progressing with additional examinations? Does age influence the minimum number of cycles?
Okay, very, very good multi-layered question. There is no one rule, no one recommendation, as far as the number of IVF cycles goes that would fit all. The age is important here. With 42 and one failed attempt, you can try again, but the success rates, as I have mentioned, are very low, somewhere between 1% and 5%. So out of 100 attempts, 1, 2, 3 successful ones. These are very, very poor chances. So that may be the major problem. And there is really no... So the age, yes, it certainly does influence the minimum number of cycles. If the patient is 32, and there's no other major issue like no response from the ovaries, then we say, okay, go ahead, please try. We'll try to work on the protocol. We'll try to improve the protocol. So 2, 3, 4 cycles still make sense. In somebody with 43, it's questionable whether the 1 cycle really makes sense. In your case, perhaps I would try one more time with a better protocol, improved protocol, maybe genetic testing of the embryo. However, if there's one good embryo, I would just transfer it and give it a chance. And if you fail again, then it's probably time to think about egg donation. Thank you for the question.
Thank you indeed as well. And of course, thank you for your suggestions. And of course, there are plenty more questions coming up. So there are like 2 short questions from Marcus.
Let's try to look at those. I do think that you have a system where if we don't make it until the time limit to answer all the questions, that you send the remaining ones to our clinic.
Exactly.
And we'll get a chance to respond to those in writing at least. Is that correct?
Yes, of course. That's what we will do. No problem, of course, here.
Okay, so sorry if we don't make it to everybody, but let's give it our best. Let's keep going.
Of course, we still have a few minutes left. And as you mentioned, we will definitely forward all the questions that won't be answered tonight to the team. And I'm sure Dr. Thomas and his team will be happy to help you out. And the question is right here. What is the success rate with donated eggs compared to own eggs? And how do you check the quality of the eggs?
Great questions. They have been actually mentioned or partially answered in the talk. The first one, what are the success rates? It depends on the age. I have mentioned that in the group where the woman is between 40 and 45, with own eggs, 1 through 3% success rate. With donated eggs, 55 through 60. So it's a different world. Of course, if it's the patient's own eggs and she's 28, then the difference would not be that great or that huge, because with her own eggs, if there's a good response from her ovaries, there's basically still that about 50% chance that she'll get pregnant from transfer of one embryo. The success rates with own eggs in the group until 35, okay, so let's say 18 through 35, the success rates with own eggs are 50 through 55%, so very close to the ones with donated eggs. So the age plays a very important role, and it's in those higher age groups where the difference shows. How do we check the quality of the eggs? There is really hardly any way how to check for the quality truly. So it's based on morphology. The eggs are actually examined after the oocyte pickup, they have to be placed in a special maturation medium for a while, and then they're cleared of everything else, so that sort of group of support cells, the cumulus oophorus, and when the egg is naked, hence the name denudation, then the embryologist looks at the egg, and there's actually a list of parameters that they go through. Is it regular? Are there fragmentations? Is the polar body well specified? But there is no easy or no simple way to just check for the quality of the egg. A polar body diagnostic might be mentioned here. When you take the polar body from the egg and you examine the polar body, in the meantime, the egg is fertilized and can develop into an embryo. But this is a rather expensive method that is not very frequently done, because it has been pushed aside by the testing, the PGTA, the testing of the embryos themselves. Thank you for the questions.
Indeed, again, thank you so much for those. And okay, let's have a look, of course, at the next one that we have. So what are the genetic exams that the egg donor has to undergo by law in your specific clinic?
Once again, they have been listed in the presentation. It's karyotype, so these are all blood tests. It's blood tests for a karyotype, so the chromosomes have to be in order, for cystic fibrosis, for muscular atrophy, and for hereditary deafness. So these four are actually given by the law. If you wish to actually, ask for an additional genetic test, such as the Fragile X, you can always inquire that. You can ask the coordinator during the preparation phase, and it can be examined in the donor. But in that case, the cost of the examination goes actually to the patient. But there can be extra tests performed from these blood tests. But these four that I mentioned, these are the rule, and they have to be part of the examination of the genetic consult. Without those, the geneticist wouldn't give the green light.
Understood, of course, perfectly. Thank you so much. And actually, there's another question from the very same patient, so let's have a look. So my endometrium always reaches at least 7 millimeters at ovulation. Can I have a natural cycle? Are the chances the same without using estrogens?
Oh, great question. Okay. 7 millimeters is good. 8 through 10, better. Natural cycle. Basically, yes. It depends, or the follow-up questions would be, do you have a regular cycle? Possibly. And what's the state of not only the uterus, but the ovaries as well? One thing that's important, the native cycle or the natural cycle, I take it, we're talking about embryo transfer here, so possibly frozen embryo transfer, not regular cycle. Ovaries are good. Okay, great. Thank you for the important addition. So yes, I like the natural cycles for the transfer, especially of the cryopreserved embryos, the frozen embryo transfers, very much. And as far as the success rates go, they're actually same in both groups. I have heard at the Congress colleagues from France, from Spain, from Germany mentioning the same, and it was fun and interesting to hear the same experience. They all said the same thing. In the natural cycles, the success rates are slightly higher, but it's not statistically significant. So it doesn't really matter. I'd say if it's a frozen embryo, then yes, let's go with the natural cycle. Let's take a look around day 11 or 12. Let's measure the endometrium, evaluate its structure. Let's take a look at the dominant follicle in the ovary, which produces the estrogen. That's the fuel that actually pushes the endometrium higher. And if everything is perfect, we might step in and time the ovulation and then eventually the transfer. However, if it's a cycle with egg donation where a donor is stimulated In there, it's not really possible because the timing of certain crucial steps is given by the ovaries of the donor. So in there, the endometrium has to be prepared with estrogens. But the success rates are about the same. They're very similar. Statistically, exactly the same. Thanks again for the questions.
Again, thank you so much. And as you can see, there's a thank you for you right here from
Oh,
the
thank
patient
you.
as well.
Very nice.
All right, and let's have a look at the next question. I guess we have still a few minutes, but of course, Dr. Thomas, just let me know, okay? And
Let's
as I
go.
mentioned, all the
Let's
rest
try.
of the questions will be sent to you.
As long as
Okay.
there's somebody still there listening, then we can give it a try.
Okay, just let me know whenever you need to, of course, go. Okay, next question is a bit longer. I will be 38 in April 2021. I have had one failed IVF attempt in December 2019 with 2 grade 5AA embryos after 6 years of trying to conceive with unexplained infertility. I have put on a significant amount of weight and now have a high BMI 40. I am working to reduce this, but I am concerned that I am aging and my eggs. Would you recommend a frozen embryo transfer at this weight, or should I lose weight first?
Thank you. Very specific, very detailed, and very helpful. A straight answer, unequivocally, yes, go for the frozen embryo transfer, because as far as I know, your body mass index, your body weight, does not really have a significant influence on the ability of the uterus to build up the endometrium, take the embryo in, and on the chances of the embryo to implant. The influence of the higher body mass index is usually felt in the regular cycle. With a higher weight, it might become irregular, problematic. It might have an influence on the ovulation. It might have an influence on the response of the ovaries to stimulation. But if you have cryopreserved embryos, it shouldn't really play a major role, and I would just go for the transfer. Good luck.
Wonderful. Again, thank you so much for your advice. And as well, there's a thank you from Emma for you. All right, let's have a look. Another question, again, it's a bit longer one. So, having had 2 cycles with low eggs numbers, 1 egg and 3 eggs, and only one fertilized, by they are abnormal. The others were immature. Is there anything that
See,
can be done to help the maturity of eggs or to increase numbers? I am 35 but have low AMH and follicle count.
the age is favorable here, but the ovarian reserve seems to be low. I kind of wonder how low the AMH is. Is it low as in 1 nanogram per milliliter, or lower than 0.3, 2.5? Is that picomole per liter or nanogram per milliliter? That's very important. If you happen to know the units, they might play a major difference here, because this in nanograms per milliliter would still be actually a fair. That would be a normal level. So I take it this is probably in picomole per milliliter, in which case it is lower. Okay, let's go back to the original questions, if we may.
Yes,
I mean,
sure.
the question, please.
Sure, of course. Just give me a second. Let me go to this one right here.
Thank you. Okay, to help the maturity of eggs. I would have to take a look at the stimulation protocols, see what the development was, how many follicles total, why only some of them were growing. Sometimes a different protocol can help to even it out. There are other tricks, such as estrogen priming. It's not very popular, but it's something that we can try. Estrogen towards the end of the previous cycle prior to the stimulation to kind of even out the follicles before we start to stimulate them. And then this could eventually lead to a more balanced growth of the follicles. But generally, if this is a question of a low ovarian reserve, and that can happen with 35, unexplained, low AMH and follicle count, I'm afraid that this is something that you'll have to struggle with. And Fort, okay, okay. Yeah, this is a very high dose of the FSH. The maximum dose regularly used is 300 units per day. 450 is really high, and I don't think there's anything else you can try. There have been ways tested how to try and increase the ovarian reserve, and some of them have been even partially successful in getting more eggs or more ripe eggs. But ultimately, the take-home baby rate, the parameter that's the really important one for us, it always stays the same. So we cannot turn back time, and there's nothing that we can really do to improve the ovarian reserve. Unfortunately, the answer there is no, there's hardly anything that you can really do. And if repeatedly the stimulations are unsuccessful, or if the AMH grows or drops further, it might be time to think about egg donation. I'm sorry. Thank you
All
for the
right.
question, Nicola.
Of course. Thank you so much again for your advice on that as well. And next question, it's right here. I want to do PGTA. How much is it better than NGS? Sorry, is
Oh,
NGS than fish?
fish is out of question. It's if it's what I think it is, that's the testing of the blastomeres on day 3. It has been pretty much abandoned. So NGS is definitely the right answer here. Okay, that's the better method. Testing or biopsy on day 5 and NGS. That's very good, because the NGS does actually give the lab a chance to see not only the major chromosomal problems, but but also balanced translocations, and there's hardly any other method that would be able to show that. I see that another question jumped up asking what is NGS. So let me tell you exactly. It's next generation sequencing. Your geneticist will know, or your physician will know. It's a specific method for the analysis of those cells that we gain via the biopsy. Okay, next generation sequencing. It's a type of the pre-implantation genetic testing.
Wonderful. Thank you for that explanation. And also, there's a follow-up. Is there any other type of PGTA on day 5 that's better than fish?
The NGS is the one to go with. So I would look no further. For the PGTA, the NGS is the method of choice. Okay.
All right. Again, thank you so much. And now let's have a look at a bit longer question once more. Okay. I will be using a surrogate, as all my 11 IVF cycles resulted in miscarriages,
I'm
even from my
sorry.
donors, whereas they gave other intended parents children. My husband and I have none of the same genetic carrier screenings. I had subserous fibroids that would grow every time I take the cycle meds, but had them removed twice. Endometriosis likewise removed twice through laparoscopy and hysteroscopy. PCOS at one point as well, now gone. So my question is, we are using a surrogate for the first time. I can't risk another miscarriage. I have PGD24 tested embryos. What can our surrogate do to have a healthy and successful pregnancy other than take prenatal vitamins? I would prefer folate rather than folic acid, probiotics, omega-3, 6, 7, 9, and fish oils. Anything else she should do?
Wow. Okay. Long history. Tough. Basically, that's it. I mean, you would be interested in her previous history, but if there were any miscarriages, you would know, right? In that case, we might want to look at the hematology, but we cannot possibly give her low molecular weight heparin just to make sure. It's not indicated, and the hematologists would go crazy, and rightly so. So vitamins, the right lifestyle, and a little bit of luck. But basically, that's it. There's hardly any simple suggestions that I could still give you. I understand that this is very, very stressful, but and I'm really sorry that it hadn't worked previously. But just look at her history. Talk to her, or have her, better yet, the gynecologist talk to her. See if she was through previous pregnancies, were there any complications in those pregnancies? Did she carry to term successfully? I take it yes, because otherwise she wouldn't probably do this. And in that case, there's nothing else specifically that I would recommend, just a good follow-up during the pregnancy. But this is pretty much standard in most of the European countries, including perhaps Greece, or I don't know where this one goes on. So just, oh my God, tons of good luck, and I hope it works.
No, of course, indeed. Fingers crossed for
Yes,
for you, for sure. And thank you so much. And let's have a look. Actually, there is a question in regards to folic acid. What quantity do you recommend taking before egg donation?
Oh, okay. Very good question. Very good question. I admit, like historically, the quantities given were up to 10 milligrams per day, but there have been some studies that have found that problematic, and usually it's recommended to not to go over 5 milligrams of folic acid per day. Nowadays, I have to admit that I usually recommend some pregnancy vitamins rather than just purely folic acid. It also depends on what the situation is in the specific patient. If there's a form of hereditary thrombophilia that is the MTHFR factor mutation, then usually higher doses of folic acid are recommended. But usually these like first trimester vitamins such as Femibion 1 are a good choice or a sure option, because there's not only folic acid in them, but also the metafolate, the metabolite already. I'd say the minimum should be 400 micrograms per day, but usually you want to go a little higher than that. And I'd say to stay on the safe side, no more than 5 milligrams per day.
All right, excellent.
Before or after, it's the same. Okay.
Okay, no, understood, of course. And we will be shortly finishing, but there are, of course, plenty more questions. So just to let you know, remember that if you would like to get in touch with Dr. Tomas and his team, you can also use this link. I have just sent it to you. There is an option to contact button to contact the team. And as you know, Dr. Tomas will be more than happy to help you out. So with any follow-ups or with any other questions, it is
Please
possible.
do. If I may jump in,
Of course.
I pardon my intrusion. Please don't be disappointed if I don't answer or don't respond directly, because I hardly would have the time to respond in typing to all the questions. But rest assured that the coordinator that you will be in care of and who will actually type up the answer will discuss the issue with me, and I pretty much dictate the answers. So there might be somebody else signed under that response, but I will have my hands in them for sure. Okay, thank you. Thanks again.
Thank you. Thank you so much for that reassurance as well. Yes, definitely needed. Thank you so much. Okay, and I guess let's have a look at the next question. But of course, as I've mentioned, Dr. Thomas, whenever you need to go, it's okay. You can tell me. Okay. And
I'm
let's
getting
have
a
a
little hungry, but I can take it. Let's go.
all right, understood then. Let's have a look at the next question then. So I'm healthy 48-year-old. I had a natural pregnancy, age 45, with missed abortion 10 weeks and diagnosed hypothyroid after but 8 months medication was normal. Since then, I have had 5 donor egg transfers, all grade 1 embryos, 5-day, 3 different donors, and only 1 embryo transfer each time. Had ERA test, hysteroscopy, thrombophilia, NK blood test, biopsy, all normal, partner, normal sperm test. I have 3 small intramural fibroids. I have 2 frozen embryos left. Can you suggest anything else?
That's a tough one, because you have been through a lot and you have listed pretty much everything that we have mentioned, including the ERA test, hysteroscopy, thrombophilia, NK blood test, biopsy. Oh my, oh my, oh my. I did have a patient who has been through 19 cycles, including some with egg donation, and the spermiogram looked perfect. It was normal, and eventually we performed because there was no other answers. She said, "Well, what can you recommend?" And I said, "Well, the only actually binding issue putting all these cycles together is the sperm cells. They were always the same. And even though the spermiogram looked really strong, we performed a DNA fragmentation test, and it showed actually a very high level of DNA fragmentation. Back at that time, we didn't have the max test to sort out the sperm cells prior to the fertilization, so I recommended donated sperm, and she got pregnant and carried successfully to term. So that was the game changer eventually. But here, this is too simple of an answer, and it doesn't really hit it correctly. 5 donor egg transfers, grade 1 embryos, 1 embryo each time. Oh my God, this is really tough. We're looking at the 2 frozen embryos, of course. With 48, I don't really recommend usually a natural transfer cycle, a native frozen embryo transfer cycle, even if the cycle is still quite regular. I would give those 2 remaining embryos a chance and then eventually think about adoption. I'm sorry, it's really tough, but I don't see any loopholes here. I mean, you have done everything right. And I'm sorry, I'm very sorry, and it hurts, but I don't have an answer.
Understood, of course. And there's another additional information. Natural pregnancy was with the same partner, also had a natural pregnancy in 2016.
Right. The one with termination doesn't really play a role. The natural pregnancy with the same partner that ended in miscarriage, that doesn't really change it. Of course, with 45, everybody's saying, okay, the major suspect here is the quality of the eggs, and yes, rightly so. But the sperm quality can also play a role, and the fragmentation can be a part of that. So that's maybe something to look into, but it's not going to play a role in transfer of those frozen embryos. You're not going to change anything there. So I would just give them a chance, and that's it.
All right.
Sorry.
Thank you once more for that, of course, question and providing all such details. And as you can see, there is a thank you from our patients for you as well.
Okay.
Right
Thank
here.
you very much for the great questions and for your attendance. Okay, it's like 20 minutes past 10 over here.
Yes, exactly. So
I am getting a little woozy, but this was
problem.
great. Thank you for this opportunity. Thank you for the great questions, and please stay in touch. I hope you get answers from our coordinators soon, which is probably sometimes next week. I'm not going to be in tomorrow, so I won't get a chance to respond prior to like Monday, Tuesday next week. But we'll get to that, and we can eventually set up that consult and see if we can like push it further. Thanks again. This was a great experience, and even though I cannot see you and I cannot really appreciate your presence, then I have felt it, and it's been great. Thank you so much, and have a great night, and good luck.
Dr. Thomas, thank you so much. And I know we will be going, but of course, as you can see, there are plenty of thank yous to you. As you can see, thank you so much. It was really helpful, very
Appreciate it.
informative presentation.
You made my
So
day. Thank you.
thank you so much, everyone, for joining, for your questions. I know it's been very interesting for you, and I just want to mention that yes, definitely we will send those, so don't you worry. And remember, it has been recorded, so you will have a chance to watch this tomorrow on our website. It will be available on YouTube channel as well. So just go ahead and subscribe. That way, you will be notified when the video is uploaded. So I can only encourage you to do that. Once again, it was a brilliant session, Dr. Thomas. Thank you so much for joining. I definitely hope we can do this again. And of course, everyone else, have a lovely, lovely evening. And well, I hope to see you tomorrow here at 8 p.m. UK time as well.
Thank
Thank
you, guys. Good
you.
luck. Stay healthy, please.
Take care. Bye.
Thank you, Carolyn.
Bye.